no matter whether they're breathing in or breathing out, that pressure is going to remain the same, okay? And PEEP, when they're getting a breath in, I'm going to, let's say we're volume control ventilation, so I set a tidal volume in at 500. Does that mean that on the ventilator during that 500 milliliter inspiratory time that PEEP goes away? No. Okay, well, no, but that's why I'm at, okay, so it's always there. There's always that back pressure. Okay.
Is it CPAP is only spontaneous?
Yeah. Okay. When you're talking CPAP, we are assuming that it is on spontaneous breaths. PEEP tends to be when there is some form of mandatory breaths from a ventilator. Okay? So, for example, I have a patient who is still intubated, but the only problem I have with them is they can breathe, they can inhale, exhale, their tidal volumes are good. However, they still need some of that pressure in the alveoli, okay? I have to keep that FRC increased, okay? But they're still intubated, and they're on a vent. So I put them on a spontaneous mode. I'm going to call that CPAP. Okay? However, if they're on a ventilator and I have to give them a rate, okay, then now I've changed it and it's going to be called PEEP. Okay? And when we go back and forth between a BiPAP machine that's done with, let's say, a V60 or some other, like a ResMed version brand, or whether it's done on the ventilator, we're going to see that we've got to make sure that we keep our terminology because we use different names for everything, right? Have you learned driving pressure at your clinical? So how would you describe driving pressure compared to what we've used for terminology in class? What would you say that?
It's in the compliance equation, it's plateau minus PV. So the amount of flow, let's answer.
Amount of pressure that's needed?
Pressure needed to something. To overcome the...
To overcome the resistance and compliance of the air, right. So basically, it's the pressure you're going to need to overcome all that. So she heard this word driving pressure. You're going to probably hear that at Floating Hospital with Dave also. When he does vents with his baby pressure ventilation, you're going to hear him use the word driving pressure too. Okay.
Just plateau minus P. Not anything like that fancy, but
what do we really call, what do we know as plateau minus P? No. Trans airway
pressure.
Or what? Transrespiratory. No, transpulmonary. Wait. What are the two pressures again? So we have trans-respiratory, trans-pulmonary,
Thoracic.
trans-airway. What pressures are we using?
Excuse me.
Yes.
See Lisa?
What?
Did you see Lisa?
No, is she here?
Oh, she came to say hi to you.
PIP minus plateau. So is PIP minus plateau your trans airway pressure? But I thought
Airway is airway opening.
which is your PIP?
Minus alveolar pressure. PIP is your airway opening?
Yes.
Yeah.
So what then your alveolar?
Plateau.
PIP minus plateau is what it takes to get through the airway. PIP minus plateau is your trans. So driving pressure is different, okay? So driving pressure is different. Driving pressure is the pressure that you need to overcome the resistance through the airways, okay? Trans airway pressure is PIP minus
Flat.
plateau.
So, but here we're saying flat minus peak.
She's
To overcome what?
saying,
Driving pressure is flat minus peak.
she's saying plateau minus P.
Yeah.
Okay. Part of the compliance equation.
Pressure you need to overcome.
No. So driving pressure isn't on the test.
Yeah.
So
P-A-W
Only talk about what we need.
and HIP are all
the
the
same.
same
We
thing.
consider those the same. Yep. Okay. So do you see anything wrong with this slide, by the way? Driving pressure is totally different. It's totally different.
Focus on that right now.
Yeah, we don't care.
Do you see anything wrong with this picture?
There's
It was in the book. It's part of the slide thing. I looked at the slide and I said, okay, this thing is wrong. Yeah, the IPAP and EPAP are wrong. Right? I'm looking at this, I'm like, who let this go by? I'm like, the low pressure is the expiratory positive airway pressure. The high pressure is the inspiratory positive airway pressure. So just to let you know, this line is wrong.
Okay.
But I'm like, I'll put it up there and see if anyone pictures. So
Isn't that the second
I know.
mistake you
I
caught?
don't know who the editor is.
With those answers that was on the
It is from your book. So, well, but so I want to point out to you that is wrong. Okay. So CPAP is spontaneously breathing. PEEP is when the ventilator in some way is controlling the patient's breath. Okay? Okay? However, if I have a patient on a ventilator that they can take their own breaths in between, and I've set it for 5 of PEEP, that doesn't mean I say on the vent, when they take their own breath, it's CPAP, but the mandatory breath is PEEP. Okay? Because the ventilator is controlling their breathing. They're still going to get it. Correct. Okay? Okay. So, breath sequences are going to be based whether or not the patient is allowed, one, to take spontaneous breaths on their own, and or do they have somewhere in their mandatory breaths. Okay, so I'm going to show you the difference here, okay? See here, ventilated breath, ventilated breath, ventilated breath, okay? There are no spontaneous breaths in here. How do I know that there's no spontaneous breath? There's no deflection, right? I see no deflection. So if the ventilator, I have set it so that the machine gives the breath, okay? Or, let's say there was a deflection here, but the ventilator is controlling either the pressure or the volume, okay? Then that ventilator is still in charge of the breath, right? The only thing the patient is able to do is to trigger. I would like a little bit more minute ventilation. So therefore, I'm going to trigger the vent. I want another breath. But the ventilator is either controlling the volume or the pressure. Okay? That's what we call controlled mechanical ventilation. Okay?
So that wouldn't be CPAP.
CPAP is not controlled mechanical ventilation.
But that's only if there was a deflection?
But if, let's say there was a deflection
Yeah,
here,
okay.
okay? But still, the ventilator is controlling either the volume or the pressure for that breath.
So whether there's a deflection or not, it's still controlled mechanical ventilation?
Correct.
Okay.
Okay? So this one here is controlled mechanical ventilation. Even if there was a deflection, I'm controlling the pressure or the volume to that patient when they ask for that breath. Therefore, it's controlled. Okay? Years ago, we used to, if we didn't want them to be able to get an extra breath, we really wanted to control everything. Basically what we did was we set the sensitivity so high that no matter how hard they tried, the ventilator wasn't going to give them a breath. Okay? We talked about that the other day. That's not comfortable for a patient. So we don't do that. Okay? What's that? Oh, if you have to do that, that patient is going to be completely sedated. Okay? Possibly paralyzed. Okay? Because it's not comfortable. This one here, so this is what makes the next breath sequence called IMV, intermittent mandatory ventilation, okay? So in between the patient taking their own breath, I am going to deliver a vent-controlled breath based on whether I want it done by pressure or by volume, okay? So for this waveform, there's no deflection here, right? The ventilator gave the breath. But in between, that's the patient's own spontaneous breath. So intermittent mandatory ventilation. What was the first one called? Controlled mechanical ventilation. That's right under
CMV.
Yep. So CMV is one type of breath sequence. IMV is your second type of breath sequence.
And so when the patient takes their own, it's their own tidal volume or pressure?
Yes.
Okay.
Yes. Yep. Okay.
But so in that waveform, those ones are given, those are the vent ones.
Right.
And then the ones in between are the patient
That's the
taking their
patient's own. Correct.
Which are not big enough, so that's why you have to give them some more.
Correct. Okay. All right. So the third one is just spontaneous, and we'll come back to that, okay? So BiPAP. If I set a rate on it, okay, so how many of you have used V60s? A couple of you use V60s? Okay. A lot of times in the emergency room, somebody comes in and they don't want to intubate them. They may say, let's put them on BiPAP. Okay. If you don't put a backup rate on there, they are controlling when they get the breath, right? Okay. So you're not forcing the ventilator to give them a breath at any point in time. Okay. However, if I put them on a set rate and that patient isn't breathing, it's going to automatically put a breath in, right? So you could be either spontaneous or mandatory, okay?
On a BiPAP? Or
Right.
So this is mandatory, this setting right here is mandatory, or is it
How am I going to know?
because of the,
No trigger.
nothing?
No
Some
deflection.
Some you may not see a deflection as well on a CPAP, BiPAP.
Are you gonna only be able to tell by looking at the screen if you set a
Sometimes.
set a rate?
Sometimes. Depends on the model and how good it is. Okay.
Maybe because of the spacing, how it's so regular. That would tell you that it's
Could
mandatory.
be. But you'd be able to tell by the rate. So this one at least is labeled correctly. I have BiPAP and EPAP in the right spot. Okay. So this is where we're going to kind of go with, how do you know? Okay.
Excuse me. Thank you.
All right, so for it to be spontaneous, the patient has to initiate the breath, okay? How big of a breath in, the volume, that's for the patient to decide. Okay. You don't take equal breaths throughout the minute. Some are bigger, some are smaller, right? Okay. So not only that, the flow is based on the patient. If you're just resting comfortably, like you're almost sleeping, it's a much slower flow, right? But if you feel like you got to do a sigh, that's going to be a faster flow. So spontaneous breath is basically the patient controls the volume, the flow, even how long that inspiratory time is. Okay. So for mandatory, who's really controlling? The ventilator is going to control, okay? For some patients, right, if we set a rate, it's time that's going to determine when the next breath comes, right? If I have them on pressure control, that inspiratory time, once that inspiratory time has been met, right, it's going to stop inspiration. So basically, the mandatory breaths, the ventilator is determining the start for the breath, how long that breath may last, depending on what setting you're in, okay? And if you're in volume cycled, it's going to deliver that volume. Trying to think of where they're mowing in comparison to where we are. It's a soccer field. I know. All right. Is everybody okay with that? Okay. So this is a lovely chart.
Is this what you meant by doing a chart yourself?
On that idea, but okay. So there's three different things it's looking at. Okay, it's three separate things on the same chart. Okay, you first look at it, you're like, oh my gosh, which direction am I supposed to go? So right here, so the type of breath. Does inspiration start because a preset pressure is detected? Okay. Yes. It's a pressure trigger. Okay, so it went from a baseline of 0 to -2. Oh, that was the trigger. Okay. If no, then does inspiration start because of a preset volume is detected? We tend not to use volume trigger. Okay, but if it was a preset volume, then it was triggered by volume. Does inspiration start because a preset flow is detected? So if I have a bias flow going through all the time at 10, and I set it for for 3, it senses a 3-liter change. Well then, yes, the inspiration is flow triggered. But if it starts because a preset time, then it's time triggered. Okay, so if I have a patient on a ventilator and I set it for a rate of 30, pretty fast, but every 2 seconds, right? It's going to be a breath. Okay, 2 seconds went by from the last time inspiration started. Boop, that's a time trigger. Okay, these, pressure trigger, volume trigger, flow trigger. Well, actually, we're going to change that. Pressure and flow are mostly patient triggers. Okay. Volume trigger has to do when a certain amount of volume has come back down. It's going to sense that it's time to give another breath. But for the most part, flow and pressure are all patient triggers. Okay. Time trigger is when the ventilator gives the breath. So when I'm looking at my waveforms, I can say by the deflection or not, whether or not it was a patient trigger or was it a time trigger from the ventilator. Okay. The next one here, so this is determining what's your limit? Okay. Does peak pressure reach a preset value before inspiration ends? Okay. So, does it reach? I set it for 30, it hits 30, inspiration ends, then you're also pressure limited. Does the peak volume reach the preset value before inspiration ends? then yes, your volume limited. Right, this is how this is gonna work.
Is pressure limited, is that the same as pressure control?
If you are in pressure control, you are limiting the pressure, aren't you? So most, where we are now, in our understanding of ventilators, if I am in pressure controlled mode ventilation, then pressure is my limit.
Same with
Volume is variable, flow is variable. If I am in volume controlled ventilation, then volume is my limit, okay? I usually keep a preset flow, you set the flow, right? So that is stays the same, but what's gonna be a variable? Your pressure, okay? All right, so that's that chart. So as far as knowing when a patient is in acute respiratory failure versus respiratory insufficiency.
Do you know what that noise is? It's very distracting.
I think it's the fan downstairs.
Yeah.
I don't think.
Oh, the blower?
The blower, yeah.
To drive the floor. Respiratory insufficiency, you do have the ability to compensate a little bit, okay? So somebody with severe COPD, okay, they have respiratory insufficiency. Eventually what you see is that their carbon dioxide levels will increase. However, their kidneys are going to start putting out more bicarbonate to try to get that pH in normal range. Okay, especially when that's kind of a slow, gradual increase in PaCO2, okay? When you're in acute respiratory failure, you are no longer able to partially compensate for yourself at that point in time, okay? However, as respiratory therapists, we have to be able to recognize when respiratory insufficiency is heading towards acute respiratory failure, okay? And some of the stuff we're gonna, some of the symptoms are similar at the beginning. All right, so why are we gonna even bother with mechanical ventilation? Okay, sometimes we feel like we know that there's no good outcome for this patient, and that mechanical ventilation is only going to prolong a disease process that cannot be fixed. But, you know, for us, it's not our decision to make. It's usually between the patient. But you know what, here's the thing. Sometimes you don't know. Like, for example, when I got sick and I had to have that surgery, you know, they had to tell me that, is that it again?
Yeah.
Oh my gosh. You know, surgery should have gone well, and everything was fine. But what if there was a complication that I wasn't anticipating? Okay. You know, I know that, you know, I always tell my loved ones, whatever you do not put me on a ventilator if I'm not going to come off. But then things happen over time, and it's like, you know, is this something I can live with right now? So it's hard for us to be in their shoes, and trust me, people have been, you know, DNR, DNIs, they don't want it, but when that second comes and there's a critical decision, the patient may ask, like, put the tube in.
We assign it a lot of those patients, and they should be, like, it's an ethical thing, Christina was saying, because, like, they're a ward of the state now, and the state does, like, there's no, what's it called, social worker for them, who has to make the decision and all of that stuff.
Yeah. So it can be very complicated. There's a section in your book that's about ethics too that we'll eventually get to. All right, so there are what they call categories. So we'll go over those, which usually leads to acute respiratory failure. And then some of the ways we determine, depending on the disease process, when they're heading towards from respiratory insufficiency to the requiring mechanical ventilation. Again, we try to prevent them from getting to acute respiratory failure and intervene prior to that. So we'll just kind of look at some of these values. Okay. So this is the big thing. Everything we like to say is evidence-based medicine. Evidence-based medicine, okay? Your AARC puts out the journals and uses evidence-based medicine, okay? They do studies. It's really a good idea to join that. to see, you know, what is going on. If you're fortunate enough or want to, and you can work at some of the more high-tech facilities, like Mass General, Brigham's, you may be part of that research for the paper and such. So this is the key thing again. Beneficial. But we can't make that decision all the time what's beneficial. Is it going to have an effective outcome? We will say all the time, listen, you know, I know this is what we want to do, but I'm not confident that if I put this patient on a ventilator, they're going to come off that ventilator. So we have to let the patient at least know that. If you're somebody with a, you know, a neuromuscular disease, yet, you know, right now you can't breathe for yourself, but you consider it improved quality of life. Okay? I love this, reduced length of stay, but Sinai, we're dealing with a totally different environment, so length of stay isn't really there, and lower mortality rate. That's what our interventions are supposed to be. Okay. So, what's interesting is when you look at the successful outcomes, oxygen is part of this, because acute respiratory failure isn't just going to be CO2, it's O2. So we have to think about that oxygen. Obviously the patent airway, if the problem is that, I know somebody in clinical they were talking about tracheal malacia. Well, you know, is that a patent airway? If that airway keeps collapsing? No. So, you know, it may require surgical intervention or a trach if that's going to work. But, and then we have to just constantly monitor. When somebody is on a ventilator, they're monitored continuously. Good Sam, I believe, puts end-tidal CO2 on all of their vent patients. Initially, yes, no?
Yeah.
Good Sam?
Most of them, yeah.
Yeah. Which is, and let me tell you, Jean Coheno, who is the department head there, she is always doing what is best for the patient and uses evidence-based medicine. So she is really doing what is right. Regardless of what some griping you may hear, her best is always for the patient.
There's a sign in the break room that says Jean Coheno Memorial Hospital.
Memorial Hospital, that's what we used to call it, because I used to work there. Or Jean Coheno Medical Center. Because she wants it to be what it should be based on everything. So she was like literally like she is on top. She's really good. So, you know, a lot of times we don't want to run serial blood gases all the time, except of course if we have some drastic values that we have to monitor. So once you get a patient stabilized, usually you're just following pulse ox and end-tidal CO2s, and then maybe an occasional venous blood gas for pH. Okay, so what is a patient who is in respiratory distress going to look like? Okay, accessory muscle use. Okay, respiratory rate is going to be elevated. Is that it?
Diaphoretic.
Sometimes it's going to be diaphoretic. Heart rate is going to be elevated. What else? Anything else?
Temperature?
What's that? They could have a lower oxygen saturation. Blood pressure could be an issue. Initially, it may be high. Okay. So you also have to look at their consciousness. So some patients that are in distress may really be beyond that point that they've actually entered acute respiratory failure. But when you first look at them, you know, you're looking at them and they're like, oh, they don't look like they're breathing much. Okay. So vital signs. So the texture of the skin. Texture of the skin, if somebody was dehydrated, you can usually tell. One of the things that isn't really in here will evaluate the patient's vital signs is, but one thing I also like to do when I find a patient in respiratory distress, I like to see what their IV fluid is running at. I have a little old lady that they're running IV fluid at 100. I'm like, yeah, one of the first things I'm gonna think of is that they've got fluid in their lungs because they ran it too high. And that happens. So when you look at these three pictures, okay, this person here is, I mean, you could just see in the hunched shoulders, he's rigid. This guy here, he's the one that's like, you know, hello, you know, he's just beyond that point. And I've been called for this. Could you come assess a patient? I think they're having a hard time breathing. I get up there. How you doing? You having a hard time breathing? Oh, you know, I said when I got back from the bathroom, I was a little short of breath walking and everything. Oh, but once I sat here, it was fine. Okay. So, I'll tell you another story after that. Okay. So most of these you covered. Okay. Flaring in nostrils is more with peds. You'll see the nostril flaring. Retracting for a severe obstruction, you may see a retracting on an adult, but for the most part, retractions we really see in children, neonates. So tachypnea, that's obvious. Noisy breathing. So you walk in the room and you hear stridor, okay? And sometimes you can hear the crackles, like from the doorway. It's like, yeah, that patient is what we call wet, too much fluid in. And then pursed lip, but a lot of our COPDers, they're like this anyways. But you can tell just by the look on their face, you know, that it's a little more exaggerated. You get it, Cheryl? Okay. Remember what chain stoking is? So it's chain stoking is
rapid shot of it.
Yeah. I meant
That's gas.
okay. Chain stoking means that you're probably trying to die. Okay. So when you get to chain stoke breathing, it's probably a good idea for them to determine was the patient a DNR or not.
Is it the same as Beyond?
Beyond's is a little different. Beyond's, it's more of a consistent.
But that's like you're gonna die too.
That can be just neurological.
Okay.
Which one is the one that has like times of apnea?
They both have times of apnea. Beyond's just tends to be a more steady, and then it's a pause.
So it's the same.
But chain stoking is like this.
It's the same. Okay.
That's Beyond's.
Okay.
Okay.
So chain stokes kind of winds down.
Winds down.
And then
Winds up, winds down, pause.
Stop.
Yep. Gasping, agonal breath. Agonal, you know, when you take your CPR classes, they kind of, they're not effective.